Is now visible.
Thank you very much, sir. Thank you. So, respected panelists, respected chair and speakers and dear audience, welcome to the webinar. And I'll talk about the wound construction in SICS. So, when we talk about the SICS, it should be only sclerocorneal tunnel incision. Why? It gives faster healing and stabilization, gives minimal astigmatism, and the incision area is covered by conjunctiva after the surgery. So there is a less chance of infection. Remember, if wound construction is not right, the next step of the surgery becomes difficult. So the plan of incision is dependent on cataract grade, pre-existing astigmatism, and condition of corneal endothelium. Include conjunctival peritomy, sclerocorneal tunneling, anterior chamber entry, and at last, the wound closure. The sclera need to be exposed and bleeding free. The size of conjunctival peritomy will be more than scleral incision. Tendons should be severed, and keep in mind the conjunctiva should cover scleral incision at the end of the surgery. The cautery is done at the incision site, which reduces bleeding and gives better visualization. We should be very careful about scleral shrinkage and corneal burn at the time of cautery. About the first scleral groove or first external incision, it will be at least 1.5 millimeter behind the limbus and appropriate in shape, 6 to 7.5 millimeter long and half scleral thickness groove. Scleral cut should be angled approximately 30 to 45 degrees because the straight perpendicular groove gives difficulty to understand the depth and has high risk of going too deep too fast. The aim of this incision is to easy delivery of the nucleus. So the size, is my screen visible?
Yes, visible.
Thank you.
Yes.
The aim is to the easy delivery of the nucleus. So size of incision depends on cataract grade, large incision needed for the hard cataract. And the commonly giving incision is straight and or frown. The frown incision gives less astigmatism. And also when the cataract grade is very hard, we can give the Blumenthal incision also. The sclerocorneal tunnel is done by crescent knife. We need to stabilize the eye by forceps or by Hodgkin. Otherwise, it will be difficult for knife movement. After deepening the external incision with crescent tip, scleral dissection is done by wriggling motion movement of crescent. Hand stabilization is important here. Movement of the crescent make the cut. We need to understand it, not the pressure or the force by the crescent. As the cornea is steeper than the sclera, entering the cornea needs the crescent being straight and slightly heel down and toe up. If heel is not down, it can go as premature entry, but too down can lead to buttonhole. Corneal tunnel is dissected through sweeping out motion. Incisional funnel or side walls of the tunnel is made by following the contour of the globe. For the beginners, there we need to understand for the crescent knife, which is the heel and which is the toe. At the time of the surgery, we need to understand and we need to keep in mind it. We also need to keep in mind that our eye is like a curve like a globe. So every side to side movement with blade need to follow the globe contour. And for the wound construction, I told that the cornea is more curved than the sclera. So the sclerocorneal tunnel formation is not straight direction. When we go to limbus to the cornea, it will be little bit upward. And lastly, the scleral tunnel is not square or quadrangular. A funnel mouth shaped tunnel where the internal part is larger than the external part is needed. And making the internal incision or entering the anterior chamber, we make it by keratome. And initial entry should be parallel to the external incision and limbus. To ensure self-sealing properties of sclerocorneal valve, we extend the incision from limbus to limbus. And remember, the keratome cuts when entering. Lastly, we need to keep in mind that the incision or wound construction in SICS is made for the easy delivery of and the self-sealing properties of the surgery. So we need the proper measurement of the incision in every steps. And the most important part for the easy delivery of nucleus, reduce the astigmatism and prevent any injury. The internal lip should be bigger than the external incision. Though the incision has the self-sealing properties, it is better to give scleral stitch for the very old patient or the rural patient or the camp area patient to prevent any unwanted traumatic complication. Wound sealing by hydration is done, and after that, the incision site must need to cover by the conjunctiva. I want to focus, and lastly, for the take-home message for this wound construction is, for three-planar sclerocorneal tunnel incision should be done always. We need to ensure the sclerocorneal pocket, eyeball, and sclerocorneal anatomy for knife and blade orientation and the movement should be remembered at the step of the surgery. And we need to maintain single dissection plane tunnel. We need to avoid the excessive force on tissue. An internal wound would be larger than the external wound. These points we should remember for the wound construction in SICS. These are the basic steps. And lastly, for the beginner surgeon, I want to focus that always keep in mind that surgery is all about control, not the force entry of knife into the eye. We need to practice the maximized control and ensure it by our movement of the finger and the wrist, not by the force. And when we learn the surgery, perfection of every steps of the surgery is needed always. Thank you.
Thank you, Dr.